Audio Jungle.
Welcome to Heartbeats from Lifelong Learning and our series on hyperlipidemia and atherosclerotic cardiovascular disease, or ASCVD. This program is made possible by an education grant from Novartis. However, the content has been created and directed by a volunteer planning committee independent of the grantor. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association or American Stroke Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The AHA-ASA does not endorse any product or device. In this episode, you'll learn about the pathophysiology of elevated LDL, or low-density lipoprotein cholesterol, and how it impacts the development of atherosclerotic cardiovascular disease, or ASCVD. After listening to this vodcast, we hope that you'll be better able to, one, identify the need for guideline-directed LDL cholesterol screening post an ASCVD-related event, either coronary or peripheral, and two, describe the pathophysiology of long-term exposure to elevated LDL cholesterol levels and its impact as a causal risk factor for ASCVD. I'm Dr. Zahid Ahmed. I'm an endocrinologist and lipid specialist at UT Southwestern Medical Center in Dallas, Texas. I work almost entirely in lipid clinics and spend most of my time seeing patients who have very high LDL or very high triglycerides. And I also do research in those same topics. My research has been funded by the American Heart Association, the NIH, and the US Department of Defense. And I'm really glad today to have Dr. Nathan Wong joining us in this discussion. Nathan, would you mind introducing yourself?
Hi, yeah. So, my name's Nathan Wong. I'm a cardiovascular epidemiologist and professor and director of the Heart Disease Prevention Program in our Mary and Steve Wen Cardiovascular Division, and also co-director of our Center for Global Cardiometabolic Health and Nutrition at UC Irvine. And I'm also a past president of the American Society for Preventive Cardiology and the Pacific Lipid Association chapter of the National Lipid Association. I've had a long-standing interest in lipids and cardiovascular disease and have been involved in outcomes research in this area, as well as a number of other areas within preventive cardiology over more than the past 30 years. It's a great pleasure for me to participate with you today, Dr. Ahmad, and I'd like to thank you and the American Heart Association for the opportunity.
Fantastic. These are our disclosures. And Nathan, we're among friends, so we'll refer to one another by our first names. And my first name is pronounced Zahid. So Nathan, one thing that I see in clinic, or one question I get in clinic all the time, is individuals asking me, why is their cholesterol so high? And they always love to say that, they're doing everything right. They're following the right diet, they're exercising regularly, but their cholesterol remains high. And I think this is a point of confusion for a lot of different people. So could you just start off by telling us what are the underlying causes of elevated LDL cholesterol levels?
Well, it's certainly a lot more than diet and lifestyle. The causes of elevated LDL cholesterol are really multifactorial, and we oftentimes don't we underappreciate the role that genetics can play. And while it's true that about 1 in 200 to 300 persons have genetically confirmed familial hypercholesterolemia, which is due to defective LDL receptors, and this can lead to very high cholesterol levels, oftentimes in the 300 to 400 range. But if one inherits the bad gene from both parents, the so-called homozygotes, you can have levels of 1,000 or higher. But even people without genetically defined FH can still have elevations due to many other factors, of course, as patients are correct, lifestyle factors can also play a role. Certainly, a diet high in saturated fat can really drive increases in LDL cholesterol, more so than actually dietary cholesterol, itself. So, an egg a day may not be very harmful, but what's more harmful are high, saturated fat sources, such as particularly from, red meat that, of course, a lot of people still enjoy. We also know that physical inactivity as well as cigarette smoking can affect lipids, particularly resulting in lower levels of the so-called good HDL cholesterol. And then this can lead to higher levels, of course, of what we call non-HDL cholesterol, which is, even a stronger predictor of cardiovascular disease than LDL cholesterol itself. So it's really a multifactorial situation, and other, lifestyle factors, obesity, diabetes can also have an impact, and the contribution of these factors really can vary dramatically from individual to individual. So we can't always say in a given patient, what is their actual cause of elevated cholesterol, except in some certainly will have this genetic familial hypercholesterolemia that can then be the driving force.
Yeah, thank you. That's a fantastic explanation. I'm glad you brought up that dietary cholesterol isn't a huge player in your circulating cholesterol levels. I think that's a misunderstanding. People think that they can't eat eggs or something like that, or you can eat eggs, you just can't eat 6 eggs a day. You can eat 1 or 2 eggs a day. But that's a very important point.
And I think what's interesting, I forgot to mention, is that, shellfish, right, particularly like lobster and shrimp, in of themselves, they're high in dietary cholesterol, but they're very, very low in saturated fat, right? And when we consume, shrimp or even lobster, right, we're seldom consuming more than a few ounces at a time. It's a very different scenario when it comes to, like a 12-ounce ribeye steak or something.
Yeah, it's a very interesting topic. I had a patient once who, for whatever reason, only wanted to eat shrimp. And so 3 or 4 times a week she would have shrimp. And of course, if you eat that much, your cholesterol level will go up, because that's a lot of cholesterol to absorb. At some point, it does affect it. But even then, her cholesterol didn't go up that much. It was only like maybe 10-20% increase. And then the other kind of interesting genetic thing that I think we talk about nowadays is polygenic hypercholesterolemia, which may explain a lot more cases than purely monogenic familial hypercholesterolemia. We're not quite at the stage where we're measuring everybody for that, but I think one day we might be.
Yeah, exactly. And, we now have these, polygenic risk scores, because the concept being that, the cumulative smaller effect of multiple genes, may play a big role. And hopefully, polygenic risk scoring will get more formally recommended in guidelines, but it can certainly help stratify risk and identify people who are at increased risk, not just due to modest effects on lipids, but also other risk factors as well.
Yeah, very cool. Okay, let me move on to the next question. Another question that people commonly ask, what about other things other than cholesterol? It's not just all cholesterol that causes plaque, right? So beyond LDL cholesterol, what's the other factors that contribute to development of atherosclerotic plaque?
Yeah, no, I think you're absolutely right. And it's true that elevated LDL really is an extremely important driver, but our our population, both patients as well as clinicians, have maybe placed, more emphasis on LDL cholesterol itself to the expense of not recognizing the contributions of other factors. And it's really, again, a multifactorial issue when it deals to what promotes development of plaque, right? And certainly, there's a lot of interest now in increase in levels of an inflammation that can contribute to plaque. Also, elevated blood pressure, diabetes, cigarette smoking. So many of our American Heart Association's life's essential eight factors, if they're not at ideal levels, they can really contribute to the development of atherosclerotic plaque. We've also, as you know, there's tremendous interest in the cardiovascular field now in lipoprotein little a, right, which is an LDL-like particle that has actually been shown to be 6 times more atherogenic than LDL particles themselves. And there's evidence that these also promote that this also promotes plaque progression. We've seen this from serial studies of CT angiography, as well as studies that data that we've published on looking at progression of coronary calcium from several of the large US prospective studies.
Yeah, cool. That's a great summary of the other things in addition to LDL that we need to think about as we move forward. Okay, so next question. There's so much medical information on the internet. There's Dr. Google, there's blogs, there's social media, there's a rise of TikTok influencers who seem like there's no boundaries on what they're allowed to say. So there's a ton of misinformation about cholesterol. And some of it says that high cholesterol is not a concern, that it's okay. And others say that lowering cholesterol with statins can cause dementia. And I can't tell you how many times I get that question. I think in clinic yesterday, at least 3 people asked me, don't statins cause dementia? So can you address some of these things and maybe give some advice to providers on how we need to talk to patients about this misinformation?
Yeah, you hit it right on the nail. This is such an important issue, and it has really done a lot of disservice in, trying to get our patients to targets. So this has really resulted in inadequate use of statins as well as other therapies among patients who could really benefit from them. And as you say, this has largely been from patients being less misled from what they see on the internet or other social media sources. For example, the use of whether cholesterol-lowering therapy may lead to dementia. So this remains a concern that many patients bring up to their physicians. And while there were some earlier small or confounded studies that suggested this may be the case, we have much more recent large-scale studies and definitive clinical trials that have really disputed this. In fact, there was a study recently published, I believe, in Neurology that showed actually just the opposite, that people who had LDL cholesterol levels below 70 had, more than 25% lower risk of developing dementia. And we also have data from really well-conducted clinical trials, such as the Ebbinghaus study that involved a PCSK9 inhibitor that showed that even achieving very low LDL cholesterol levels, which got down to around 30 milligram per deciliter in that study, were not shown to adversely affect cognitive function. And this was measured objectively, both before started therapy and after the approximately 2 years on treatment. Now, of course, we don't have 15 or 20-year follow-up data, but there's certainly no signal of this. And there's also been raised from what people see in the media, right? Fears of statins causing diabetes. And this has been largely blown out of proportion. Now, we know that there is some evidence that statins increase blood sugar levels. And once you get over that 126 threshold, you're technically defined as having diabetes. But the effects of statins in raising blood sugar levels are very modest. In fact, certain clinical trials have shown that even if you're not on a statin, you're almost as likely to develop diabetes, maybe just a few weeks later. I'm referring to data from the Jupiter trial. And what patients really need to understand is that when the risk-benefit ratio is far in their favor. So there's a wealth of evidence from numerous randomized controlled trials, right? That statin treatment, for example, a reduction in LDL cholesterol of every millimole per liter, which is about 40 milligram per deciliter, results in about a 20% reduction in cardiovascular risk. So when you're getting a high intensity statin, you're really lowering your risk 30 or 40%, and this far outweighs any slight increase in risk of diabetes that can largely be controlled by diabetes medication anyway. So we should be much more concerned about the often irreversible effects on major adverse cardiovascular outcomes like heart attacks and strokes, that for which there's a wealth of data showing that that LDL cholesterol control, not only from statins, but from some of the newer therapies like PCSK9 inhibitors, as well as bempedoic acid and even ezetimibe in our ACS patients, really far outweighs any very minor effects on diabetes that could be largely treated. So hope that helps address this point.
It does, and I think it gives a lot of things for the average provider to talk about when somebody asks these questions. And you're actually reminding me of a story that's told around our institution a lot. So I work at UT Southwestern, and there are two guys named Brown and Goldstein who discovered the LDL receptor and won Nobel Prizes for it. We were also one of the first places in the US to do studies with statins. And there was a lot of criticism. At least these are the stories that were told. I was only like 10 years old when this happened, but the stories that are told were that everyone told Brown and Goldstein and the other investigators that we were going to make everybody crazy, that the brain needs cholesterol, and if you lower people's cholesterol, everybody's going to go crazy and have schizophrenia or this and that. Now, I mean, statins have now been around for 40 years. It's pretty clear that they don't cause people to go crazy. I think that's pretty well established. There's not that's not a concern.
Yeah, and maybe just the opposite is true. And we just have to realize now, since that time, and I remember doing my college thesis on Brown and Goldstein's work a few years before they got the Nobel Prize, actually. And
oh wow.
And I've been involved in LDL since 1982, I guess you could say. And
oh wow.
And it's interesting, back then it was really this observational data that we had, right? And really the lipid research program clinical trial came out in the late 80s, and then we really didn't have data showing the benefits of statins until the 4S study came out in the mid 90s. So it's really been an amazing journey to watch the evidence accumulate that really in a span of 40 years, we've really gone from what was really just an LDL hypothesis generated from observational data to now really very strong clinical trial evidence and its incorporation in the guidelines for who should receive statins and what levels of LDL cholesterol levels should be achieved in certain patients. But still, we're far from getting there in clinical practice. So, have many gaps that remain to be addressed.
That's very true. There's still a lot of work to do. So on that note, let me move on to the next question. And this is something that's been evolving over the last few years, but in people who have already had an ASCVD event, what is the current guidelines? What is the current recommendation for how to manage their LDL cholesterol?
Yeah, well, that's a wonderful question. And, I must say I've seen the evolution of these guidelines, because when I first started on faculty here at UC Irvine, ATP1 had first come out, and we were happy if our highest risk patients were treated to an LDL cholesterol of below 130. But we've really come a long ways with the accumulating evidence from our clinical trials, really showing that the lower the better is where we need to be. And so currently our guidelines from the American College of Cardiology and American Heart Association, first of all, recommend a high intensity statin, right, as foundational treatment for really all who have pre-existing ASCVD. So that the concept being that we really have to think of not just statins, but even non-statins, not just as cholesterol lowering drugs, but ASCVD risk reducing drugs. And, and it kind of reminds me of when, Greg Fonroe at UCLA, used to say, that, we have to get these patients thinking of them as drugs, as your heart medication, right? This is your heart medication, and not just to lower cholesterol. And one of the things that our 2018 guidelines introduced was that, many of these patients with ASCVD have multiple additional risk factors and have suffered multiple events. So they're considered very high risk. So we have a strata that represents roughly about 2/3 of our ASCVD patients that are considered very high risk. And our updated 2022 expert consensus decision pathway, as well as the recent acute coronary syndrome guidelines that just came out recently, earlier this year, really point to trying to get that LDL below 55. And then in our quote, lower risk ASCVD patients that are quote, not in a very high risk category, but I would still claim they're at high risk, that cut point is 70. And what's interesting is that our European guidelines recommend for people with recurrent ASCVD events that they should be even lower, down to below 40 milligram per deciliter. And I do a lot of work in India with the Lipid Association of India, and for our South Asian patients who are at extreme risk, we're really recommending LDL levels below 30 milligram per deciliter, because remember, South Asians are getting cardiovascular events, particularly myocardial infarctions, about 10 years earlier than other populations. So our other international guidelines are just not felt to be strict enough for these higher risk populations. And one thing also is I've been involved with work in coronary calcium for over 30 years, and there this has also been incorporated into our cholesterol management guidelines, going back to 2018, when it was noted that someone with a calcium score of, say, 100 or greater, or 75th percentile or greater, should be recommended for statin therapy. And in a recent statement in JACC Advances I was involved with, led by David Marin, we took this one step further, and kind of supporting what was also in the 22 expert consensus decision pathway from the ACC, where we noted that if your calcium score was 300 or higher, and we know that these people have risks similar to those with pre-existing ASCVD, that they should perhaps also be treated to these lower targets of below 55 milligram per deciliter. So we've seen really quite an evolution in our guidelines, bringing lower and lower LDL targets to our highest risk populations, and we really need to do better. There's still a lot of people, roughly half of these very high risk individuals with ASCVD, believe it or not, have not had a lipid profile in the last year and are not even on a high intensity statin. And of those on a high intensity statin, only about half are at, or fewer are at, reasonable targets. There is still underutilization of non-statin therapy, and I know we're going to talk about combination therapy later on, so I'll save my comments on that till then.
Yeah, we will. I thank you for going over that. I really appreciate that you point out these exact numbers for guidelines. I mean, certainly, there's always some leeway with the numbers, but you point out the exact numbers. And I will say that the first time I heard the Lipid Association of India's recommendation to get an LDL below 30, I was a bit surprised. I thought that was very, very aggressive. But the more I think about it, and the more I think of my own family, because there are many people in my family with very premature coronary heart disease, even starting in their 30s, in their fourth decade of life, they've had MIs, and so, I mean, I would even say get it less than 30, but do it really early in life. Don't wait. That's the other thing, is we tend to treat people in middle age, but with South Asians, if we're gonna be philosophical about it, I would even say get it done as early as you can. Get the LDL down as early as you can in their life. But on that note, okay.
Yeah, that is such an important point, and I think, the problem is that, we find out about people with high cholesterol later in life and then start treating them, but we really want to prevent these increases in LDL cholesterol right from the very beginning, because we know that it's a cumulative life years of exposure from LDL cholesterol that matter more than this finding a high level later in life. So this is so important, right? And it kind of gets to the controversial point about how early should we start treating, because we know that if we treat early in life, your 10-year risk of cardiovascular event is still quite low, right? So from a number needed to treat standpoint, when you start early and just look at the horizon of 10 years, it's still not very convincing, but the point is as you're right, we need to try to keep people's cholesterol levels low throughout their life course.
Mhm. Yeah, so on that note, what are the current treatment options to help achieve all these LDL goals? Not just a number, but how long we keep it low.
Yeah, so I think as I mentioned earlier, right, we're still, what's interesting is that most of our guidelines are still focusing on a stepwise approach, right? And statins, of course, have the longest and most convincing evidence from multiple clinical trials. And besides being generic, so these are, of course, the foundational treatment for most people as long as they can tolerate statin therapy, and most people can. But what we're not doing is really thinking about non-statins and non-statin use. Even ezetimibe, which has been out for decades and is now generic, it is still quite infrequently used, right? And in our current current guidelines, and the most recent recommendations from 2022, as well as the ACS guidelines, right? The focus is really on, ideally, ezetimibe or a PCSK9 inhibitor, given their evidence for reducing cardiovascular outcomes. Since the 2022 document was published, of course, the CLEAR Outcomes trial involving bempedoic acid, which many clinicians still have not heard of, that also shows significant cardiovascular benefits. So these are the main non-statins that can be used. Bempedoic acid, interestingly, acts in the same pathway as a statin. Instead of inhibiting HMG-CoA reductase like a statin, it inhibits ATP citrate lyase in the liver. That's a couple steps above and is not activated in the skeletal muscle. So you don't get some of this myositis that you might see in some patients from statins. Certainly, we also have inclisiran, a small interferon RNA therapy that prevents the production of PCSK9 from the outset and lowers LDL cholesterol levels with time average reductions from injections at baseline, 3 months, and every 6 months after, of around 50%. And that's can be compared to bempedoic acid, which is an oral daily therapy given roughly 15 to 20% reductions in LDL cholesterol. Now, ezetimibe, of course, has been out the longest. It's a cholesterol absorption inhibitor. You get about 15% further LDL cholesterol reduction. I oftentimes think of ezetimibe as a kind of as a glass half full and half empty, because the IMPROVE-IT trial really only showed a 6% relative risk reduction, and that was in these very high risk acute coronary syndrome patients within 10 days of their ACS, whereas PCSK9 inhibitors, of course, have been proven in a much broader range of ASCVD patients to lower event rates. And bempedoic acid, we also have data from the large primary prevention population that was examined in CLEAR Outcomes, showing an even greater 30% risk reduction. So we have many, these several very useful therapies that are still underutilized and really need to be considered in appropriate patients to get them better treated to target. We're, of course, anxiously awaiting the cardiovascular outcomes data from inclisiran, and hopefully that will be out in the next few years. But this certainly promises to be a valuable therapy that will hopefully reduce cardiovascular outcomes as well.
Yeah, okay, so you brought up a great point about clear outcomes and that the primary prevention group, it was a high-risk primary prevention group, actually seemed to benefit, and correct me if I'm wrong, they benefited more than the secondary prevention group. And maybe maybe we need to think about that a little bit more. And the way we design studies and things.
Yeah, what a lot of people don't recognize is that, as far as non-statins, bempedoic acid is really the only one where we have cardiovascular risk reduction benefit proven from the clear outcomes in the primary prevention population. So, for the first time, we really have a good non-statin option that we can hang our hat on for the primary prevention group.
Yeah, that's a really important point. Okay, so let's say we're going to prescribe these medications to patients. Their first question is often going to be, okay, what's the side effects? So what do we need to tell patients that they should be aware of when they're prescribed these treatment options?
Yeah, so, certainly with, patients, right, they're concerned about the muscle pain. And yeah, this can occur certainly with statins, but what's interesting is there's data such as from the Samson trial that really compared, people on statins versus a placebo, and then found that what was interesting was that there was really no significant difference in symptoms between those taking a statin versus placebo. So it really kind of raises question about how much of these patient-related symptoms after they take a statin would have really occurred anyway had they not been on a statin. So I think the whole point about statin intolerance is largely overrated, and most clinicians agree with that. And before you really consider someone to be statin intolerant, you really have to show that they failed 2 statins, including one at the lowest dosage. There's also been, concerns about, liver enzyme abnormalities, and this is relatively uncommon. And there were issues with a prior statin called cerebrastatin, which is not really used anymore. And then also when people were combining statins with gemfibrozil, which is not really done anymore. So this has largely been a non-issue over recent years, and in fact, we don't even necessarily recommend routine liver enzyme monitoring like maybe we did years ago. And as far as some of the newer therapies, the PCSK9s and inclisiran are very well tolerated and have really no important side effects, except some people do suffer injection site reactions. In the case of bempedoic acid, someone with active gout, it would be contraindicated because we do see increases in uric acid that can occur. And there has been some data about tendon rupture being reported, but this is largely an inconsistent finding that hasn't been shown in some of the more recent trials, and it's quite rare. And certainly I appreciate any comments you may have as well, since you directly treat these patients.
Yeah, I agree with everything you're saying. I think overall lipid-lowering drugs are a very safe drug class, or classes of drugs, and Generally speaking, most people do tolerate statins, but there are those that they say they have a problem, and that's really challenging to work around. Um, it kind of depends upon their own state. They may or may not say that they're willing to try another statin. They may say they'll never try another statin again, and you just work with it and find things that they can take and that their insurance will pay for and get their cholesterol down. Um, I guess we should be thankful that these individuals still do want to get treated for their cholesterol. In today's world, there are so many people who don't want to get treated. Um, that
Yeah, and again, I think it's so important that the clinicians spend the time with the patient explaining the benefits and the convincing data showing cardiovascular risk reduction benefit from statins as well as several of our non-statins, because patients need to know that benefit risk ratio, and that there may be some side effects, and they may not necessarily be due to the therapy, but it could occur. And the fact that roughly 50% of patients are not under prescribed statin after a year, right? The data show we really need to improve this, and there has to be a constant communication between the clinician and the patient about the benefits, and are they taking their medicine. This is so important.
I agree, and I like the point you made that we really need to discuss things and spend some time on this, because every patient is motivated by different things. Some patients, if I tell them my personal story, which is I take a statin, and I know many of my colleagues who are physicians also take statins, sometimes that helps convince them. Um, you know, but for other people, they don't care. They think that physicians are, we're just brainwashed by pharmaceutical companies. And so you may have to go into more data with such individuals that come from sources that are not sponsored by industry or something, which is available out there. I mean, there are plenty of statin studies that were NIH sponsored or independently sponsored. And so
Yeah, and
it's
I
an
think
interesting thing.
it's just important that patients understand that our large scale clinical trials, right, you do have independent data safety and monitoring boards, that and that and the data are so scrutinized by the FDA, right, before there's an indication. So you don't see this from nutraceuticals that are not regulated by the FDA. So I think this is very important point.
Yeah, I get that question a lot. What can I do? What can I take that's natural? And when people say natural, they're talking about supplements, but and the nutraceutical industry. But I don't consider those things natural. I mean, natural would be like eating fruit or vegetables, not having something in pill form that is not regulated, that no one has really looked at clinical trials or side effect profiles. And so it's a conversation I have quite often.
Yeah, no, and the perfect example of this is of course fish oil capsules, right? So, and people don't always understand that the nutraceutical fish oil capsules you buy at your nutrition store are not regulated by the FDA, right? And many of these contain saturated fat and other impurities, which we wouldn't want to give to our patients. But what we do know is, the FDA approved prescription icosapent ethyl, right? Pure EPA, and the data behind it from the Reduce It study showing a 25% risk reduction, right? And so, patients can, get the prescription therapy that's proven, or they can take their chance and buy something over the counter and not know what they're getting.
Yeah. And I'll just share one more thing. It doesn't have to do with lipids, but there's a recent report from the FDA and others about arthritis supplements and that they were contaminated with corticosteroids.
Oh,
And in fact, at our institution, we have at least 10 cases over the last year of people getting adrenal insufficiency, secondary adrenal insufficiency, after being on these arthritis supplements and then suddenly stopping them. You know, it's you don't know what you're taking when you're buying something in the supplement section of a pharmacy. I'll just go on to the very last question. So the last question is about combination therapy, which we touched on before, but can you kind of elaborate on the role of combination therapy in managing people with very high LDL cholesterol?
yeah, no, it's a good question because, what's interesting is the lipid field and lipid guidelines are sort of behind what we've been recommending in terms of like for hypertension treatment, right? It's recommended to start with a fixed dose combination if you're more than 20/10 systolic diastolic millimeters of mercury from target. We have many fixed dose combinations to treat diabetes, but our guidelines have really focused on more of a stepwise approach, right? Starting with statin therapy, and part of this, really may be that it's only fairly recently, right? Except maybe with the case of ezetimibe that we have cardiovascular outcomes data from these newer non-statins, but but I think we certainly need to rethink this, and particularly in our highest risk patients, right? Like with acute coronary syndrome, we want to get their LDL down as rapidly as possible because their risk of an acute recurrent event is in that immediate post ACS phase, right? So we want to try to get the LDL down as quickly as possible. And we know that some patients are going to require more than that approximately 50% LDL lowering that a high intensity statin will give you. And these effects, in fact, are even highly variable, right? Not everybody gets that 50%. Some get more, some get a lot less. So, there are, some people have recommended that maybe we start with both statin and ezetimibe. Say if we need more than 60% LDL lowering, and maybe if another 20% LDL lowering is needed, add bempedoic acid or a PCSK9 inhibitor if even more than that is needed. And it kind of reminds me of a study I was recently involved in it with colleagues in India that we published in the Journal of Clinical Lipidology several months ago, and these were among ACS patients, and they were put on a triple combination, high intensity statin, ezetimibe, and bempedoic acid, and these patients achieved more than 60% LDL cholesterol reductions within 2 weeks. So that's dramatic and can go a long ways into preventing these recurrent MACE events that are most common in the early phase after an ACS. So we need to think more about this, and hopefully guidelines in the future will recommend an approach that, depending on the amount of LDL lowering from the outset, that certain combination therapies can be recommended from the outset to achieve that. So I think it's a very important point.
Yeah, and I'll add on to that combination therapy from the onset could also help address some disparities that exist in the treatment of people with very high cholesterol. We just published a paper also in the Journal of Clinical Lipidology showing that in patients with familial hypercholesterolemia, if they were of lower socioeconomic class, as indicated by lower income and lower education, they actually do get high intensity statins, but they don't get anything beyond that. Not even ezetimibe, which is cheap and generic. You can kind of make an argument that maybe they shouldn't get, it'd be hard to get the expensive new medications like PCSK9 inhibitors or bempedoic acid, but they don't even get ezetimibe. And if they have FH, they very often need these medications. And so I think, one potential way to address that is to go ahead and start with combination therapy in the beginning if their LDL is so high that it looks like they probably need it. Maybe future guidelines or future studies will take that into account, and we'll see more data about that or more recommendations. Okay, that's pretty much all the questions we have. Nathan, is there anything else you wanted to mention or any other comments that you wanted to make?
Well, I think I've said more than enough. It's really been a stimulating discussion with you, Zahid, and really have enjoyed participating. I'll just, close by saying that, where we still have a long ways to go to get, despite all the available therapies that that we have and the guidelines, right? There's still a long ways from being implemented, and we need better systems approaches, such as even direct to patient messaging and electronic health record messaging to physicians to help aid them to deal with this remaining problem of inadequately controlled LDL cholesterol. There's a long ways to go on this, and until we do better, we're still going to have a lot of residual risk, not only from inadequately controlled LDL cholesterol, but other inadequately controlled risk factors as well. So I think we're very grateful to organizations such as the American Heart Association, as well as others that are really helping to further educate our clinicians through programs such as this. And it's been a great honor participating with you on this today, and thank you for the opportunity.
Yeah, the pleasure is all mine, Nathan. I learned a lot from you, and I look forward to learning more from you in the future. And on that note, I'll just mention in closing that we thank all of you all the audience for participating in this Heartbeats from Lifelong Learning with us today. We heard a lot of important points about why cholesterol is high, what medications are available, the side effects, misconceptions about side effects or about dementia and other things. And if you want to get additional information and or claim credit, please visit learn.heart.org. Thank you.
Thank you very much.
Audio Jungle.